بسم الله توكلنا.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. How are you? So, I don't know if if I met all of you, but just I will give you a quick introduction about myself. I'm Dr. Nof Abdullah. I am a breast imager. So I'm gonna talk to you today 2 hours about breast imaging. I divided the lectures into 2 parts, and I called it 101 and 102. I'll try as much as I can that we talk general and we start from basics, and then we will go up. I have lots of material. I will try to cover all of it, but if not, then probably we will cover the most important part. So I will start first by talking about breast imaging mammography interpretation. And the first thing that you probably need to know is bi-rads. What's a bi-rads? You will always hear about it, why we talk about bi-rads, and what should we know about breast imaging. So bi-rads, it stands for Breast Imaging Reporting Data System. The reason why we have it is because we need to standardize reporting. So, and I report in Jeddah, understand it, the person in Canada should understand it and should understand the meaning of that report and what would be the next step. And we will try to reduce ambiguity of any finding. So this is really important. And you probably would know the same if you've been through bi-rads, pi-rads of the prostate, li-rads of the liver. It's the same idea. And fortunately, we have 3 bi-rads lexicon. So because we use mammogram, ultrasound, and MRI for interpretation of breast imaging, so we do have a lexicon for each modality, and this is great. Once you master the bi-rads of these 3 modalities, breast imaging would be very easy for you. It needs a little bit more of experience, but with more practice, if you read more, if you see more cases, you will find yourself that at the end, breast imaging is not difficult. When I used to be a resident, breast imaging was one of the worst subjects that I don't like. I always feel that it's a bit difficult. We didn't have good teaching. We didn't know how to characterize lesion because we didn't study the lexicon very well. And when I did my fellowship, I completely understood from the first day. Once you understand bi-rads, it would be very easy for you. So the first thing we need to go, I will go through the bi-rads of mammography. And the first thing that we always say, the first sentence in any mammogram report is we have to talk about the breast composition of the kind of the breast that you are looking at. And there is a reason for that. So we will talk about breast composition, and then we will talk about the lexicon of the lesion on mammography. And then we always talk about associated findings. And at the end, you have to give a category assessment. So any mammogram report, you should get all of this. So you will talk about these 4 parts, and at the end, you will give your category assessment. And of course, you have to give your recommendation. So breast composition, we have 4 types. And these, what I always advise you guys that you remember these descriptors. So we will say almost entirely fatty breast in keeping with ACR type A, and I will show you example. And then the second type is scattered fibroglandular densities, and then heterogeneous dense breast and extremely dense breast. And this is exactly how it looks like. So this is the first type of breast that we see, almost entirely fatty breast. And when you look here, you can see that the breast is completely fatty. There is no fibroglandular tissue. And on the previous bi-rad, edition, we used to use percent of the breast density available. So if there is less than 25% glandular tissue, we will call it almost entirely fatty breast. In the new bi-rads edition, the last one, they removed the percent. However, I still use it. I find it helpful and useful. And you can still keep it in the back of your mind whenever you're looking at the breast and trying to characterize what type of breast you're looking at. You might ask yourself, why are we talking about breast composition? And this is a very important question. The reason for that is when I look at almost entirely fatty breasts, I know that the sensitivity of mammogram is very good or excellent, reaching up to 100% to pick breast cancer. While when I talk about the fourth type, which I will show you shortly, which is extremely dense breast, I know that it's very easy that you will miss breast cancer. And anybody who did breast imaging would know certainly that we've missed breast cancer on mammogram with extremely dense breast. The second type of the breast is what we call a scattered fibroglandular density. So if you look at this mammogram, you will see that there is some fibroglandular whitish area in the breast. You are still able to see what's behind these areas, and you will be able to see if there is any masses. So scattered fibroglandular density on the all bi-rads, if you have 25 to 50% of the breast tissue is composed of fibroglandular tissue, then we are talking about this bi-rads type, this ACR type B. The third type is heterogeneous dense breast, when you have 51 to 75% glandular tissue, as you are looking here. And once we started to look at ACR type C or D, I know that the sensitivity of mammogram is really going down. And at that point, when I see this kind of the breast, I know that probably you might need to do compression view, you might probably need to do tomosynthesis, and definitely you will need to do an ultrasound to be sure that you're not masses. The last and the fourth type is extremely dense breast, when all the breast density is very white. And I'm telling you from my experience, it's very easy to miss cancer in this kind of breast. And usually you have more than 75% of breast glandular tissue. And there is a way how to look at the breast when it is this kind of breast density. So we finish about the breast composition. We go to the second important part of the bi-rads, which we call the bi-rad categories. So we have 7 categories of the bi-rads, starting from 0 to 6. And when I say bi-rad 0, it means that looking at the mammogram, it is incomplete assessment and I need to do further imaging. And this further imaging, it could be compression view, it could be magnification view, or ultrasound or MRI. So you need to do something else to further characterize the breast that you're looking at. When I call bi-rads 1 and 2, it means that this mammogram has either normal or benign finding, and I'm not worried about it. When I call bi-rad 3, the implication of that is it is a probably benign finding. What does that mean? It means that what I see has a probability of 98% to be benign. However, there is 2% that this mammogram or this finding could be malignant, which is very small percent. It means another thing. So it means 98% it is benign, but you need to do a short interval follow-up. And usually the way of follow-up in bi-rads 3 is very known. So you do 6-month follow-up for 2 years. So what I always say, you do first 6 months, and then after another 6 months, completing 1 year, and then you would do the second year after 1 year. So total of 2 years follow-up. Once everything is stable, it will be downgraded to bi-rads 2. What I call bi-rads 4, it means I need to do biopsy, and there is a percent of being malignant, and they say probably malignant. However, bi-rads 4 has 3 categories, for A, for B, for C. You don't need to know a lot about that, but at the end, whenever you call bi-rads 4, it means that we need to do a biopsy for this lesion. When I call bi-rads 5, it means that it is malignant, and when I call bi-rads 6, it means that this is a biopsy-proven malignant lesion. So this is very important to understand and know. Okay, moving into mammography. So as we said, bi-rads has its own lexicon for mammography, for ultrasound, and MRI. And for mammography, these are the 4 most important categories that you need to know. So in cases of the exam, if you go to the exam and you have breast imaging cases, definitely either you will be facing a breast mass or a microcalcification or architectural distortion, or you might face one of these special cases. So you have to know how to describe these findings. So we will start with these findings in details. So the first thing, whenever you are looking at a mammogram, and this is really your usual general life when you're looking at mammogram, not for exam purpose, the first thing that you have to check is you have to check the technique, be sure that the technique is adequate. And then check the availability of any previous mammogram. Keep that in mind when you are doing your exam, because when you mention that, I would like to know if this patient had a previous mammogram, there might be some mark on that, and I might show you the previous mammogram that could help you in your final assessment. And then always check if there is history of previous biopsy, surgery, or any previous biopsy results. Talk about the density of the breast that we talked before. You have always to check if there is any hidden zone. And then you have to talk about, look at the axilla, look at the medial breast and the deep aspect of the breast. And these are hidden zone in the breast. We'll talk now about breast masses. So the definition of breast mass is important. So it's usually a 3D space occupying lesion, which means that I will be able to see margins of this lesion on any two orthogonal views. Usually it has a convex outward border, and this would differentiate a mass from an area of architectural distortion. And it would differentiate a mass from an area of asymmetry when you see it on only one view. So the definition of a breast mass, it is a space occupying lesion. Once you describe that this is a mass, these are the things that we have to talk about. You have the shape, the margins, and the density. And if I want think that would characterize that lesion, I'm sorry guys that it's moving like that. The most important is the margin. So as you can see, and this is, you can go back into the bi-rads lexicon and you will find it. So the shape, you have round, oval, lobular, irregular. The margins, you have circumscribed, microlobulated, indistinct, spiculated. In the density, you have high density, equal density, low fat containing lesion. As I said, the most important is the margins. So generally speaking, if you have a microlobulated margin or indistinct or spiculated margin, then you have to keep in mind that you are dealing with a malignant lesion. The rest of the finding here is not very helpful to characterize the lesion. So this is talking about the breast masses, round, oval, lobular, irregular. So these, the 3-1, they could be found in benign or malignant lesion. The irregular lesion, usually you find it in malignant lesion. So this is just an example. So if you look at this image, you see that the mammogram, you have a rounded lesion. So round, I know that most likely I'm dealing with a benign lesion. Another shape is elliptical or X-shape. Usually it is benign. However, some of the malignant lesion, they can present as what you can see here. Lobulated, when you look at it, when you have these small undulation on the margins or on the shape of the lesion, again, this could be benign, could be malignant. So it's not very specific. When you look at a lesion that is very irregular, similar to what you see here, this is very classic for malignancy, except if the patient had history of previous scar or previous surgery, then this is something could be considered in the differential diagnosis. So this is your differential diagnosis for round, oval, or lobular lesion. And always think common is common, think about the age. So the most common that we usually see as a round, oval, lobular lesion, cyst, fibroadenoma, papilloma, sebaceous cyst. However, keep in mind that cancer can present as a well-defined lesion. The differential diagnosis of irregular masses, the most common is cancer for sure, and then post-operative scar, radial scar, fat necrosis can present as irregular shaped lesion, and cancer, as we said. So this is something you always keep in mind, the differential for a regular lesion. So as I said before, we talk about the shape of the lesion, the margin of the lesion, and the density. The most important feature for assessment that could help you to identify what is the diagnosis is the margin. So whenever you look at the lesion and you want to assess the margin for exam purpose, you would say, I would assess the margin further by compression magnification view. These days, we don't do any more magnification views because we have the tomosynthesis. So when we look at the tomosynthesis, we are able to identify the margin of the lesion. And these are the descriptive for the margin. So you have a circumscribed lesion, you have a microlobulated, you have an obscured, indistinct, or spiculated. So circumscribed, it is self-descriptive. It's very easy. Microlobulated, when you have a small lobulation, as I showed you. The difference between obscured and indistinct: obscured is you think that there is an overlapping tissue preventing you from assessment of the margin. Indistinct is when you have the lesion infiltrating into the adjacent tissue. So usually, generally speaking, if we're talking about indistinct or speculated margin, we're talking about a malignant looking lesion, and we're talking about probably bi-rads 4 or bi-rads 5 lesion. And this is just an example. So this is where a circumscribed lesion look like. So the definition of a circumscribed lesion as per the bi-rads is abrupt transition between the lesion and the tissue, where 75% of the lesion you will be able to identify it as margin. This is your typical description for a well-defined circumscribed lesion. We talked before about fibroadenoma, we talked about cysts, and then you might get cancer that have a well-described, well-circumscribed cancer, and this is the 3 types. So always remember peanuts, M&Ms. So the papillary cancer usually present as a well-defined lesion. Medullary and mucinous cancer, they are usually presenting with a well-defined lesion. Microlobulated is when you see these tiny lobulation in the breast. You will be able to see them best on tomosynthesis or on compression views. When I see something like that, most of the time it is malignant. It is not usually seen in benign lesions. That you think that overlapping tissue preventing you from looking at it. Sometimes you might do compression view, however, you will not be able to identify all the margins. And in that case, you will need an ultrasound for further characterization. Indistinct, similar to this, so you think that the mass is probably infiltrating into the adjacent tissue, and this is usually indicate that this lesion is suspicious relatively. And again, whenever I see something like that, you will need to do either a compression view or you look at the tomosynthesis very carefully. Speculated is when you see a mass, 3D space occupying lesion, and when you look at the margin, you see these sun rays appearance or spicules radiating from the lesion. Whenever you see this, this is highly suspicious for malignancy. This is your differential diagnosis for speculated lesion. We talked about it. Cancer, usually tubular cancer is the typical. Radial scar, post-operative scar, there is other differential diagnosis, however, they are not common. So I would stick with these 3 important differential diagnoses for speculated lesion. We talked about fat necrosis before, also one in the differential diagnosis. Mass density is when you look at the attenuation of the mass relative to the adjacent fibroglandular tissue. It's not very helpful because we know that sometimes isodense masses can be benign or malignant. We know that dense masses, they can be benign or malignant. It is very helpful when you have a fat-containing lesion. So either you are dealing with a galactosele or you are dealing with a hamartoma. So this is your differential diagnosis for fat-containing lesion: lipoma, fat necrosis, galactosele, oil cyst. So when you see this, then you will see I'm dealing with a bi-rads 2 lesion. If you have mixed fat and tissue density, hamartoma, lymph node, so you always look for the kidney shape, intramammary lymph node, fat necrosis, or galactosele. And this is just an example of these fat-containing lesions. So you see there is a well-defined oval-shaped lesion with a dense areas within it, fat component. This is typical of hamartoma. Once I see that it's a bi-rads 2, this is just a lipoma. This is a kidney shape or rounded lesion with a central fat-containing area. This is in keeping with intramammary lymph node. So all of these findings is a bi-rads 2. As I said, mass density, if it's low, it's not helpful. Could be cancer, could be benign. If it's equal density, not helpful. If it's high dense, it's not very helpful. So to summarize, if I'm dealing with a mass and I'm looking at the mass, what should I do? So usually the first thing we do a routine mammogram. Just keep in mind, if I go back, mass approach, probably the age of the patient is important in these cases. So if you're dealing with a patient who's less than 30 years, less than 40 years and coming with a palpable mass, I would start with ultrasound and then maybe I will do mammogram. In contrary to that, if I have a patient who's 40 years and coming with a palpable mass, no, I would do a mammogram. If I'm doing a routine screening mammogram and I have a mass on it, then your first thing is you want to look, do I have fat within the mass? If it's fat containing, it's benign, nothing to worry. If it's round, oval, or lobulated, we said you always do focal spot magnification view. You might have the tomosynthesis and it will help you. If it shows you that the lesion is well defined or speculated, it is helpful, but at anything similar to that, you have to go for the ultrasound. The reason why you always need to do an ultrasound for any masses is because mammogram will not help you to differentiate between solid and cyst. So I always need to do the mammogram. So I will do the ultrasound. If it's a cyst, then it's benign. I have nothing to do. If it's solid, then it's probably suspicious. This is, we have done it, the focal spot or the tomosynthesis. This we did it with the mammogram before the ultrasound. If it's solid, then you have to characterize that lesion based on the ultrasound finding that you're looking at, and we will discuss shortly. So from the mammogram, if you did focal spot or tomosynthesis, as we said before, the margin of the lesion and the shape of the lesion and the other finding that we're gonna discuss, it might help you to characterize that lesion, and then you will need to do the ultrasound. So generally speaking, whenever you're looking at a mass on a mammogram, your first question is, I want to be sure that I'm dealing with a mass. I want to be sure, am I dealing with a focal mass or an asymmetry? And then you will talk about what is the exact location of this lesion. Why? Because when I take that patient to ultrasound, I need to know, so is it a lesion or an axillary lesion? And then I want to know exactly what is the specific clock location of that lesion, how far that lesion from the nipple, and then you will do your assessment based on the mammogram finding. So if you have a CC view, right or left, and an MLO view, for example, so you have to keep in mind on the CC view, whatever is located in this side, this is lateral part of the breast. Whatever is located on this side, it is the medial side of the breast. And it would be variant depending, are we dealing with a right or a left breast? In MLO view, if you have something here above the nipple line, then this is superior part of the breast. Anything below the nipple line, it is below the nipple line, so I'm dealing with something inferior in the breast. You always also you have to keep in mind that when we do the mammogram, we do two things. We do CC and MLO view. MLO, which means mediolateral oblique. We don't have a mediolateral straight view. So since we do an oblique view, it means that we have some obliquity of the view, which means that it does not give you an accurate location on the MLO view. So generally speaking, when you have a lesion, this round oval lesion in the lateral part of the breast, so this is CC view. So for the junior resident for R1 and R2, anything located here, we said lateral, anything located here, medial. So let's say that I'm talking about the right breast. So located in the right lateral aspect of the breast, this lesion, and I see it located here on the MLO view. So if you draw a line from the nipple perpendicular to the pectoralis muscle, so I know that this lesion, it is located below the nipple line, so it is located inferior in the breast, in the right breast. So this lesion, it is located lateral and inferior, but this is oblique view. So you know that if I do a true lateral, the location of the lesion will be different. So how can I know? So always remember, muffin rises and lid sink. What does that mean? It means that this lesion in the right breast located lateral. And on the MLO view, it is located here. So if I have, imagine that you are doing a true lateral view. So lateral lesion, which is L, lateral, lid sink. It means that this lesion, if I do true lateral view, it will go down on the true lateral view. So if it's located here on the MLO, I would imagine that if I do a true lateral, it will go down because it is laterally located on the CC, so it will be located here. Does it change much? Not really, because it is still located in the lateral inferior aspect of the right breast. Which clock location? So right lateral inferior aspect, it means it's probably located from 6 o'clock to 9 o'clock. So this is where I'm gonna check on ultrasound to find that lesion. So this is an important part that you should understand. So for example, I'm looking at this mammogram, MLO-CC view. I have this well-defined rounded lesion in the MLO, and I have it on the CC. So am I dealing with a real lesion? Yes, I am. I will do a compression view or tomosynthesis to see the margin of the lesion. Am I dealing with a mass or asymmetry? I am dealing with a mass because this is a space-occupying lesion. How far is this lesion from the nipple? It is located in the mid-zone, so it's about 3 to 4 centimeters from the lesion. What do you think about the margin? So it looks well-defined, circumscribed, so I think I am dealing with a benign lesion. What is the location of this lesion? So this lesion is located on the CC view. You see it is located on this side. So you draw a line from the nipple posteriorly. Anything on this location, it is located medial breast. So it is located medial inferior. So left breast. So if I do my true lateral, we said muffin rise, muffin, medial. So medially located lesion will go a little bit up here, okay? So it is medial, a little bit here. However, it is still below the nipple line, so I am dealing with a medial inferior left breast mass. So imagine the left breast as a clock location, left medial inferior, so it is from 6 o'clock to 9 o'clock of the left breast. Most likely, I will find it at 8 o'clock. صح? Why? Because it is, if on a true lateral, it would be located here. It is close to the posterior nipple line, so it is most likely at 8 o'clock. So this is where I will find it on ultrasound. The other thing that you have to keep in mind, guys, is the arc technique. What's an arc technique? For example, if I have a lesion located on the MLO, and I'm not sure where is the location of this lesion on the CC view. So how can I be sure? You have to find the lesion with a similar density, similar size, similar appearance on the CC view. This is number one. The second thing is I will measure with my hand from the nipple into the lesion. For example, I have 3 centimeters. I will point with my fingers to the lesion from the nipple. And then on the CC view, I will draw an arc with a similar distance from the nipple. Anywhere along this arc where I find similar density, similar size mass, this is most likely corresponding to this lesion. So this lesion, for example, it's located here and it's located here on this. And this is just an example. So what you do is, this is my lesion. I will measure with my fingers how far from the nipple. I will draw my arc. I will measure on the MLO, draw my arc, and then I will be able to tell that this lesion is the same as this lesion. And then I will give exact clock location, and I will try to identify that lesion on ultrasound. So we finish the masses. We will move into special cases. What are these special cases? So you have architectural distortion. You might have dilated tubular asymmetry or density, intramammary lymph nodes, and the asymmetry spectrum. And this is really, guys, what you need to memorize. So these are the descriptive terms that we will talk about. So what's the definition of an architectural distortion? Architectural distortion is when you look at the breast and you see that there is no areal mass. However, you see a thin spicules radiating from that area, very tiny, thin spicules. And this is how it looks like. So when we look at the mammogram, you see here that there are isodense or dense lines radiating. However, there is no underlying central mass. This is another example. The differential diagnosis of architectural distortion, similar. So radial scar is one. Cancer is another differential diagnosis, or post-operative changes. What do I need to do when I see an architectural distortion? And this is in cases of exam, you have to ask immediately. You have to be spontaneous. You say, I would like to know if the patient had history of previous surgery. If there's no history of previous surgery, I would ask for an additional view as compression magnification view, or you have the tomosynthesis, we will be able to see that this is a real finding or not. And then if you know that you still have persistence of the finding of architectural distortion, then you will move to do an ultrasound to identify the finding. The second descriptive term of special cases is dilated tubular density, where you see sometimes an asymmetry or a density of a tubule. And this is how it looks like. So sometimes you see that this is what I call dilated tubular density. Dilated tubular density, most of the time it is a dilated duct. The important part is you will do an ultrasound to check if there is an underlying intraductal lesion. And this is what you have when you do a ductogram. You opacify the duct and then you see a filling defect within the duct. The differential diagnosis for something like that, it's an intraductal papilloma or cancer. So this is something you keep in mind. What is your differential diagnosis? Common is common. Duct ectasia is the most common. DCIS, Munder's disease, where you have a dilated vein, thrombosed vein, or it could represent just a tortuous vessel. You always ask, once you see that, if the patient has history of nipple discharge, because if she does, then it could be related to duct ectasia or intraductal papilloma. Intra-mammary lymph node is one of the special cases. So typically, the most common location of intra-mammary lymph node, you will find it in the right upper outer quadrant. The second most common location, you find it in the medial inferior aspect of the breast. I would advise you, and this is what we have been advised when I did my training, whenever you see a well-defined lesion in the right upper outer quadrant, don't jump directly and say that this is an intramammary lymph node, because sometimes it could represent a small cancer. So to call it definitely intramammary lymph node, you have to be able to identify the fatty hilum within the center, and it has to have the typical kidney shape appearance with a radiolucent notch. If you don't say that, then you have to do a compression view or an ultrasound to be sure that you're dealing with an intramammary lymph node. On ultrasound, it has a typical appearance. It has a hypoechoic cortex, central echogenic hilum, similar to any other lymph node. If you put Doppler, you will be able to identify that there is a vessel going into the central aspect, and this is typical of intramammary lymph node. Moving on now into the asymmetry spectrum. So the asymmetry, we talked already about masses, we talked about distortion, we talked about dilated tube, and then the asymmetry. The asymmetry, it is a spectrum. We have global asymmetry, we have focal asymmetry, we have asymmetry, we have developing asymmetry. So 4 descriptive terms. What's the difference of asymmetry in comparison to mass? So we said before, masses, usually it's a space occupying lesion. So you will see that there is convex outward margins. In cases of asymmetry, there is no margin for this lesion. It just looks like a density. And asymmetry has replaced the description of density that we used to use long time ago. Nowadays, we don't use density anymore. So what's a global asymmetry? Global asymmetry is regional or diffuse increased density in one breast if you compare it to the other sides. Important things that you keep in mind is you need to ask about history if you have any previous, because if this persistent and it's known and we've seen it before, then most likely this is nothing to worry. If this is the first time that the patient is coming, you ask, does she have any palpable finding in that area or not? And then you probably need to do compression view, roll view, or you look into a true lateral, or you need to do tomosynthesis image. So if I compare right to left, so the right and the left, they are not symmetrical. You can see that the left breast has more density or asymmetry. So I see that there is large area of the breast. It is composing more than 25% of the breast parenchyma. So I am dealing here with global asymmetry. However, there is no underlying mass. I don't see convex margin. I don't see speculation or microlobulation. So I'm dealing with global asymmetry. Focal asymmetry, it is very similar to global asymmetry. However, the size of the density you're looking at is small. So these are areas of focal asymmetry. This is typical of focal asymmetry. Again, very important to ask about previous imaging, palpable abnormality, and you try to find it on the other view. What's the difference between focal and global asymmetry and asymmetry? So global and focal asymmetry, you have to see the finding on two views. So I see something, it is located on two views. Asymmetry is when I see something only on one view, either CC or mediolateral view. As in this case, so you have an area of asymmetry, I do the MLO, I don't see anything corresponding to this area, so I'm just dealing with asymmetry. Developing asymmetry is different. Developing asymmetry is you have a previous mammogram, and then you are looking here and you see that there's something new on the new mammogram. Why is it important to understand the difference between global, focal asymmetry, developing asymmetry, or just an asymmetry? Whenever I talk about global asymmetry, focal asymmetry, most of the time it is benign, representing glandular tissue. Asymmetry is usually it is an overlapping fibroglandular tissue, nothing to worry. Developing asymmetry or underlying malignancy. So if you have an area that is developed and was not seen on the previous, you have to be very careful. So far we finished masses, we finished special cases. We will go now into the second big category, which is breast calcifications. And these are your descriptive terms. So based on the bi-rads lexicon, the last edition, you have typically benign, you have the intermediate, or the suspicious. This is actually was on the old category. They removed it anymore, and now we have only benign or malignant lesions. So to know these calcification, it's very helpful to know what are the typically benign, because once you know them, you don't need to do anything further. Vascular, coarse, rod-like, round, punctate, lucent center, milk of calcium, suture, dystrophic, these are all benign. Intermediate, when you have amorphous or indistinct, based on the morphology. So if I see these two, I need something else to help me to decide if this microcalcification are suspicious or not. And then you have coarse heterogeneous, these are suspicious now. Probability of malignancy, pleomorphic, fine branching, grouped or clustered, linear, segmental, these are very suspicious. Regional or diffuse, this is depending on the distribution. So if I want to recap just for you, there are typically benign microcalcification. These are the ones. Once you know how they look like, they are usually bi-rads too. Intermediate or high probability malignancy, these are the one. And then, as I always say, guys, whenever you're looking at microcalcification, we look at two things. We look at morphology of the micro, and this is the morphology. And you look at the distribution of the micro, and this is the distribution. So if you want to keep in mind, what are the distribution that is usually benign? Diffuse, scattered, benign. Regional could be benign or malignant. Segmental is very malignant. Linear is usually malignant. Grouped is usually suspicious. Fine branching or casting is usually suspicious. So the only one that is usually benign, it is diffuse or scattered. So how to assess microcalcification? So as I said, microcalcification, you would assess morphology and distribution. And then if you have any previous imaging, stability of these microcalcification is very helpful. So if you have a previous mammo and I want to see, is this microcalcification stable or not, it would be helpful. Benign calcification, these are the ones that you need to memorize, and I will show you examples. So looking at this skin calcification, you will see it in the skin. if you are asked in the OSCE or in the MCQs how to evaluate or to know skin calcification, usually by doing what we call a tangential view. So this is something you need to memorize. So for skin calcification, I would do tangential view for confirmation that I'm dealing with skin. Another example, skin, you will see it at the periphery of the breast. You will see that sometimes it has a lucent center and sometimes it has a polygonal appearance. Vascular calcification, typical description is parallel or tram-tack appearance, and this is how it looks like. These are benign bi-rads 2 calcification. Popcorn, it looks like a popcorn. Usually it is related to calcified hyalinized fibroadenoma, and this is how it looks like. Keep in mind, guys, though, because there is the coarse heterogeneous calcification, sometimes they look like similar to this. So when you have coarse heterogeneous, it doesn't look the typical appearance of popcorn. You have to be careful because sometimes high-grade ductal carcinoma in situ can present like that. So I would be very careful looking at it. Rod-like calcification, these are very classic appearance. They look linear. However, if I compare it to the linear suspicious, they are a little bit coarse in comparison to them. So you will see them usually bilateral, they're usually diffuse. These are bi-rads 2. Round calcification, it's self-descriptive. They are very well defined rounded. They are usually benign. If you see the typical rosette, means like you see bi-rad. Punctate, these are the one that I say, they are very tiny and they are usually round. Punctate, they can be benign or malignant, so you have to be careful. You would check the distribution. If the distribution of these microcalcification is diffuse, most likely I'm dealing with benign. If the calcification of these microcalcification is usually grouped, linear, segmental, it is usually suspicious. Lucent center, they're usually benign bi-rads 2. I'm not worried about it. Eggshell calcification, they're usually benign. Usually dealing with fat necrosis, bi-rads 2. Milk of calcium, very important, guys. Why? Because milk of calcium, they can look like benign. So you need to think about something. So as we said before, any microcalcification you have to do, once you see microcalcification in the breast, and these doesn't follow the distribution of benign, so they are not scattered, they are not diffuse, your next step is you have to do what we call magnification view on CC and true lateral magnification view. Why? Because I want to find milk of calcium. Milk of calcium, if you look at them on CC view, they're usually very fuzzy, smudgy. You might think that they are suspicious. Once you do true lateral magnification view, you will be able to see them. So this is just an example. So if I'm looking at this mammogram, you will see that there is a grouped punctate microcalcification or amorphous microcalcification. If I just see this, this is bi-rads 4A, patient need to go for biopsy. So what's your next step? Your next step is you have to do magnification view and a true lateral magnification view. When we did the true lateral magnification view, you can see the cupping appearance, the linear appearance. This is so classic of milk of calcium. So from a bi-rads 4A on this image, this microcalcification turns to be a bi-rads 2, no need for anything further. And I can't tell you guys how many times I've been receiving cases to go and do stereotactic biopsy. And every time I do true lateral magnification view, I can say that there is milk of calcium, and this patient will, you will save these patients biopsy. So always remember, whenever you're dealing with a microcalcification, you have to do this. This is just another example. So you have a grouped amorphous pleomorphic microcalcification. When you do true lateral, clearly identify that there is cupping appearance of milk of calcium appearance. This is bi-rads 2 microcalcification. Another appearance of milk of calcium. You have the cup, teacup appearance with layering, bi-rads 2. Suture calcification, they look like sutures. These are bi-rads 2. Dystrophic calcification, these are happening in cases of previous trauma, previous radiation therapy. They're usually coarse. They have lucent center, look like that. So this is patient had history of previous surgery or radiation therapy. These are benign. However, keep in mind, again, if you look at this, you can see that these are coarse heterogeneous a little bit. So coarse heterogeneous calcification, they can be malignant. So you have to be very careful. You have to evaluate them carefully because they can be representing cancer. So this is something keep in mind. Moving into amorphous or indistinct and coarse heterogeneous. So I told you before, these we used to say that they could be benign. Now, any coarse heterogeneous calcification, they're usually bi-rads 4, needs biopsy. Amorphous or indistinct, you need to see the distribution. If it is grouped and it's the first time and you did the magnification and you saw no milk of calcium, then they are benign. Probably benign bi-rad 3. If they are grouped and new, then they are bi-rads 4. So really, the morphology of amorphous or indistinct, it really depends on the distribution. So always, as we said, do magnification view, do true lateral view. If they are stable, it could be still cancer, or if the patient has high risk, you probably need to do biopsy. So this is an example. Grouped amorphous microcalcification, I would be very careful. If they are new, I would biopsy bi-rads 4A. If they are first-time mammogram, I would maybe call it bi-rad 3 for follow-up. If she comes back on follow-up with increasing, then it is probably suspicious. Again, similar appearance, morphology, amorphous, very fine amorphous, how distribute, suspicious. This is bi-rads 4, highly suspicious for ductal carcinoma in situ. In this case, similar appearance, however, you can see that they are diffuse. This is benign. This is bi-rads 2. I don't need to do anything for it. Similar appearance, you do through lateral magnification view. You see that there is milk of calcium. So this is bi-rads 2, milk of calcium, nothing to worry. Coarse heterogeneous, I talked to you about before. We used to call coarse heterogeneous benign or intermediate probability. Now you have to be careful. If it's not related to fat necrosis or calcified fibroadenoma, it could be in 60% related to cancer. So you have to be very careful. So these are two examples of coarse heterogeneous microcalcification. They both have been biopsied. This one is grouped coarse heterogeneous, turned to be calcified fibroadenoma. This is coarse heterogeneous in a linear, slightly linear distribution, turned to be ductal carcinoma in situ. The microcalcification that are definitely malignant are the fine pleomorphic, fine linear branching. Once you see these are cancer. So if I want you to memorize how does fine pleomorphic look like, they always look like as if you had a piece of glass that is broken into tiny, tiny small pieces, similar to tiny small pieces of glass. So when you look here, you see that these are slightly in a segmental distribution. This is bi-rads 5, very suspicious for malignancy. So biopsy, even if it's stable, when you look here, these are grouped micro, some of them in a linear distribution. This is very suspicious for malignancy. It is associated with asymmetry and possible speculated lesion. You need to biopsy. Another fine linear, you see that they are very pleomorphic. They are located along distribution of a duct. You see these V-shape appearance, finger-like. These are very suspicious. Dot dash appearance. You see this, guys, tiny, tiny dots with dashes appearance. This is very suspicious. So we finished the morphology of the microcalcification. Now we will talk about the distribution. So these are the descriptive terms that you need to memorize, guys. Grouped or clustered. Now we use only grouped. Linear, segmental, regional, diffuse, scattered. As I said before, diffuse, scattered, benign, bi-rads 2. Regional, it could be benign, could be malignant. Segmental and linear, they're usually malignant. Grouped or clustered, it could be benign, could be malignant, depending on the morphology of the microcalcification. Okay. So what's the description of grouped microcalcification? When I say about grouped, it means that I have more than 5 microcalcification within 2 cc volume of the breast. So this is suspicious. Segmental, when you have microcalcification with a triangular appearance pointing toward the nipple, this is very suspicious micro. Another segmental distribution with pleomorphic appearance, very suspicious. Regional, when you have more than 2 cc volume, looking at this is sort of regional because it's not involving the whole the breast. Diffuse scattered, when you see it involving all the breast, this is very benign appearance. Bilateral, I'm not worried about it. So to conclude, whenever you're looking at calcifications, we said you look at morphology, you look at distribution, and you ask about previous mammogram to see if it's stable or new. What is your workup for microcalcification? You always compare with previous. So you always say, I would like to know if this patient had a previous mammogram. Typically benign, they have the typical appearance that I showed you. It's a bi-rads tube. If you're not sure, your next step is I would do true lateral 90 degree. If I think that I am dealing with skin calcification, you will do tangential view. If you do spot compression, CC, spot magnification, CC, and spot magnification through lateral, 90 degree, and you see milk of calcium microcalcification with the typical appearance of cupping, then I'm dealing with a bi-rads tube. If I do the magnification and I don't see the typical appearance of milk of calcium, and you see amorphous, fine, indistinct, pleomorphic linear, then most likely I'm dealing with a suspicious micro. Most likely I'm dealing with a bi-rads for microcalcification. On ultrasound, you will need to go back and do stereotactic guided biopsy. So this is your summary, guys. So in this, we learned about breast density. You learned about the bi-rads categories. We talked about breast masses. We talked about special cases, including architectural distortion, dilated duct, asymmetry spectrum, and we talked about assessment of calcification. So this is what you need to know about mammography. So the first part, take home points from this. You have to keep in mind that mass margin is the most important when you're looking at the mammogram. Be sure that you will look at the compression view and tell your examiner, I want to do compression view or tomosynthesis view to look at the margin. Be sure that the technique is good. If you see microcalcification, the way how you work up microcalcification is you will look at magnification view, and you will look at tangential view, and you will look at true lateral to be sure that it is not milk of calcium. If there is no milk of calcium, you will go ahead and do an ultrasound to be sure that there is no associated masses. If there is no ultrasound, then you will proceed with a biopsy for the microcalcification. So the first part of the lecture, guys, is done. Let's take a few minutes, and then we will proceed with the second part.
Dr. Ano?
Yes.
Thank you very much. Do you prefer to keep all questions at the end of 2 lectures or one by one?
Maybe it's better at the end, yes.
Okay, that's good. Thank you.
So we'll take a few minutes, and then we'll proceed.
Okay, thank you.
Okay, should we start, Doctor?
تفضلي دكتورة.
Okay, so we're going to talk now about part 2. It's mainly about ultrasound, MR, and then if we have time, we will go through the interventional procedure. Okay, so for breast ultrasound, the indication of breast ultrasound is very variable. I would always say that really depending on the age of the patient. So if we have a patient less than 40 years coming with whenever you're looking at a mammogram and you see a mass, we use ultrasound for lesion characterization. We will use ultrasound to differentiate between benign and malignant lesion. In cases of breast cancer, you will always need an ultrasound. In cases of patient who has augmented breast, you will need an ultrasound. In cases that you need to do a biopsy, ultrasound is the easiest way to do the biopsy. And then when you have a patient young, less than 40 years, usually you will start with ultrasound. I prefer to do ultrasound for male breasts instead of mammogram because it's less painful and no radiation exposure. And then you might hear about what we call a second look ultrasound after MRI. So if we talk about characterization of lesion, I think ultrasound is the best modality to differentiate between benign and malignant. I would say it's even better than MRI and than mammogram. So your first question is, you always, when you see lesion identified on mammogram, you want to be sure, am I dealing with a solid versus cystic lesion? Because common is common. If you have a cyst, then cyst is usually benign. I don't need to come and do anything for it. If you have a solid lesion, you have to characterize that lesion further, and you have to know, are we dealing with benign versus malignant based on the ultrasound finding? So in cases of assessment of, just give me 1 minute, guys. Okay, so if I talk about solid lesions, there are special features on ultrasound that can help you to differentiate between benign versus malignant versus indeterminate lesion that you're not sure and you probably need to do biopsy or not. So what are the findings? So whenever I look at ultrasound image, I always ask myself 2 questions. Looking at the ultrasound image, my first question, am I dealing with benign or malignant? So am I dealing with something that I can be 100%, it is bi-rads 2? If I can't answer that question, then I will ask myself, am I dealing with something that I would call bi-rad 3? If it doesn't fit, then it means that I'm dealing with something that is bi-rads 4, suspicious for malignancy. So you need to know what are the features of malignant lesion on ultrasound. So as we said on mammogram, we will talk about the shape, the margin, the echogenicity of the lesion or the internal characteristics. So looking at the margin of a malignant lesion, you always look, do this lesion have the typical speculation? Does it have an angular margin? Does it have a microlobulated margin? Does it have echogenic halo? And here I'm telling you what you can use to help you in the exam. And it's not completely, I wouldn't say that this is completely depending on the bi-rad lexicon, because some of these features has been removed from the bi-rad lexicon, like an echogenic halo, but I find it's one of the most helpful finding whenever you're looking at a mammogram, at an ultrasound. So if you see speculated lesion, you know that you're dealing with something malignant. If you think you're having an echogenic halo around the lesion, you know that you're dealing with a bi-rads 4 lesion. If you see an angular margin, you know that you're dealing with a bi-rads 4 lesion. If you see a microlobulated margin, you know that you are dealing with a suspicious lesion. So any one of these is a bi-rads 4 immediately. The only exception is if you are dealing with a small lesion, meaning that a lesion that is smaller than 1 centimeter, and you see that you have a microlobulation, then in that case, you know that this lesion still can be benign, because the lesion that is smaller than 1 centimeter, it will not have a macrolobulated margin. So this is just an example of suspicious lesions. So you look here, you see that definitely you have a speculation here. You have an angular margin, an angular margin, an angular margin here. So I'm dealing with a malignant lesion. This lesion, it is relatively well-defined lesion. However, when you look carefully at the margin, you can see that there is a microlobulation. If this lesion is bigger than 1 centimeter, it will be suspicious to me and I would biopsy that lesion. If you look at this lesion is slightly in this feature. This lesion more suspicious. When you look here around the lesion, you see this thick echogenic capsule around it. This is very suspicious. It means that this is a bi-rads 4 lesion. Another lesion that you can see that there is a microlobulation. There's areas of thick echogenic capsule. This is a bi-rads 4 lesion. What other features that make the lesion suspicious on ultrasound? So the shape of the lesion is helpful. If you have a rounded lesion, it could be benign malignant. But when you have a taller than wider lesion, so you see that the AP dimension of the lesion is bigger than the mediolateral dimension, you have to be careful that this lesion might be malignant. If you see a focal dilated duct and the lesion is extending into the duct, that is suspicious as well. If you see the lesion has a branching pattern, it is extending into an adjacent multiple duct, then these are very suspicious and you have to biopsy the lesion. And this is just an example. So if you look at this, for example, image, you see that there is slightly indistinct margin, focal hypoechoic. You are not sure if this is a dilated duct only or not. And then you see that there is a branching duct. You have another branching duct. You have an echogenic component within this duct. This should be suspicious for you, and this would be called as a bi-rads 4 lesion, and you need to biopsy that lesion. So this is bi-rads 4. What other features that can help you? Internal characteristics, I don't find it very helpful. So echogenic lesion is not helpful. Sound transmission, so if you have posterior acoustic shadowing or posterior acoustic enhancement, it's not helpful. It could be benign, could be malignant. Calcification, it's not very helpful. If it could be benign, as in case of milk of calcium, it could be malignant, as in case of ductal carcinoma in situ. So the calcification, not always helpful, but sometimes it can help. So this is just another example. Let's move. You see here, these are areas of calcification. If I want to characterize these are coarse heterogeneous with posterior acoustic shadowing. Is it helpful? No, because it can be related to fibroadenoma. It could be related to cancer. So I cannot judge based on this. So it doesn't help me much. If I look at this lesion separately, you see that it has slightly indistinct margin. It has a microlobulation a little bit. It has internal calcification. I don't see anything capsule around it. So by all means, looking at this mass, this is bi-rads 4 because it has calcification, it has a microlobulated margin, and there is no thin capsule, so this is suspicious to me. Okay, what are the findings for benign solid nodules? So we said these are the one that discussed was malignant. The finding of benign lesions are the following. If you have pure or intensely hyperechoic lesion, it means that you're dealing with benign lesion, probably fat-containing fat necrosis. If you have a well-defined elliptical in shape, oval in shape, it means it's benign. If you have gentle lobulation of this lesion, like it has a very smooth lobulated margin, it is usually benign. If it has thin echogenic capsule, it is benign. So you have to memorize these because once you see these features, probably you're dealing with probably benign lesion as a bi-rads 3. So this is a typical example. So this is something I want you to keep in mind, guys. You have a well-defined oval-shaped lesion. It has thin echogenic capsule. It is slightly, I would say based on the image, slightly heterogeneous. So heterogeneous lesion could be benign, could be malignant. But based on the lesion shape and the margin, this is a probably benign lesion. You will characterize it as a bi-rads 3, and you will advise for a follow-up in 6 months. Another lesion, very well defined, thin echogenic capsule. This is bi-rads 3 for follow-up. So what should I do in characterization of lesion when I look at lesion on ultrasound? The first thing, as I said before, look for the classic malignant finding. If you have classic malignant, speculated lesion, heterogeneous lesion, microlobulation, angular margin, it's easy. It's a bi-rads 4 or 5. If you don't find them, then look for benign features. What are the benign features? Oval shape, homogeneous hypoechoic lesion, thin echogenic capsule, bi-rads 3. If I have echogenic lesion, then I'm dealing with a bi-rads 2 because fat-containing lesion. If I don't find any of the features that we talked about, bi-rad 3 or bi-rad 2, then I go back into square one, which means that I'm dealing probably with a suspicious lesion, bi-rad 4, and I need to do biopsy. So we move now into differentiating cyst for a complex cystic lesion. And this is something really important, guys, to keep in mind. There is a difference between a cyst and a complex cystic lesion. When you say cyst, it means that you're dealing with bi-rads 2. When you talk about complex cystic lesion, it means that you're talking about bi-rads 4. What is the definition of a simple cyst? Simple cyst, it has to have these criteria. It's an anechoic lesion. It has to be well circumscribed. It has to have thin echogenic capsule. It has to have through transmission and thin edge shadow. This is typical appearance of cyst. So anechoic, edge shadow, posterior caustic enhancement, thin imperceptible wall. This is bi-rads 2. I'm dealing with a simple cyst. Complex cystic lesion that doesn't fit the criteria for simple cyst. So you have to think, am I dealing with a simple cyst? No. Am I dealing with a complex cystic lesion? Yes. Is it solid or benign? Let's look at the images. So for complex cystic lesion, what is the definition of a complex cystic lesion? Complex cystic lesion means that the wall of the cyst is thick. It might have a solid nodular component. It might have an internal vascularity. If you see any of the following that I mentioned, then you are dealing with a complex cystic lesion. What's the bi-rads of a complex cystic lesion? The bi-rads of a complex cystic lesion, it's usually bi-rads 4 and above. So these are what we talked about. So if you have thick isoechoic septation, mural nodules, vascularity, multiple microlobulated appearance inside it. So looking at this, guys, so you have areas of anechoic. However, I have an internal echogenic component. I'm not sure if I have a solid component. So looking at this, guys, if you get thickening of the septation or vascularity, then this will make this lesion as a complex cystic lesion. People who did breast imaging, they might question, what's the difference between this and a clustered cyst? Sometimes it's very difficult, guys. Clustered cyst is when you have a tiny cystic areas within this. You have very thin internal septation. You don't see vascularity within it. Then this is clustered cyst. Clustered cyst is something that is mentioned in the bi-rad lexicon, and it's usually bi-rad 3 or bi-rads 2. When you have lots of fibrocystic changes in the breast and you get to see something like that, it's most likely clustered cyst. If you're worried, I would advise to follow up. If you think it's nothing, there is no vascularity, all the breast has multiple findings like that, then it's a bi-rads 2. If you look at this one, you have an anechoic cyst with a solid component. Once you see this rounded solid component, then your description is complex cystic lesion. This is a bi-rads 4. It needs biopsy. Even if I put flow, there is no vascularity. This is a complex cystic lesion. It has to be biopsied. This is just another example. You have a little bit of thickened septation. You have a solid nodule. This is bi-rads 4. It has to be biopsied. Another description is when you have this predominantly solid lesion, however, it has an internal cystic component. Once you see the internal cystic component, this can be called as a complex cystic lesion. Is it solid? It is solid. However, you can call it as a complex cystic lesion because it has lots of cystic component. This is bi-rads 4. It needs to be biopsied. If you put color flow and you see vascularity within the cyst, then this is complex cystic lesion. It has to be biopsied. What are the features of bi-rads? Rads 2. So if you see features that might suggest inflammation, you would call it as a bi-rad 3 for follow-up. If you see hyperemia of the wall, not an internal solid component, you can call it as a bi-rad 3 for follow-up. If you see uniform isoechoic thickening with no vascularity within it, you still can call it as a bi-rad 3 for follow-up. And this is just an example. So an inflamed cyst is something that you commonly see in breast imaging. Patients, they're usually around 40. They come with a palpable mass, very painful before the period. You look at it, you see anechoic cyst. You see posterior caustic enhancement. You look at the wall, it is hypoechoic. You have a hypoechoic wall. You might find increased vascularity around it. This is an inflamed cyst. I will call it a bi-rad 3. Similar appearance, the same thing, posterior caustic enhancement, no vascularity. I would follow it up. Why is this important? Because I am telling you from experience, this lesion, it could be cystic, however, it could be solid lesion. So you have to be very careful. So I would advise, you might argue with me and you say that the margin of this lesion is not well defined. I completely agree. I would not fault you if you want to biopsy this lesion. Yeah, I agree. The same thing here. If you think that the wall within the cyst is thickened, you think that it is too much for you, then I would advise for biopsy. Yes, no problem. You should biopsy this lesion. But this is just an example of an inflamed cyst. This is just another example. When you see here, you can see that there is vascularity. This is should biopsy. This one, if you think there is no vascularity, you still can follow it up. Part of the complicated cyst that you might call as a bi-rad 3 is when you are faced with breast infection or mastitis or abscess. So you look at these image ultrasound, you can see that there is very irregular shaped mass lesion. There is internal echogenic component. You look that there is some areas of echogenic halo around it, but you come with the classic history of patient coming with fever, redness, she was lactating, and then she came with this. So you know that you are dealing with mastitis, and this is probably part of a breast abscess. The same thing here. This is just an inflamed fat. You have an inflammation with some fluid around it. So this is an area of mastitis with an abscess. So something like that, the clinical history is extremely helpful and important. So if you have a young lactating patient coming with symptoms and you have this picture, then most likely you're dealing with mastitis and abscess. You would correlate clinically. Probably you can aspirate. You can give the patient antibiotic and do follow-up in 2 to 3 weeks. But if the patient is coming, she's 60 years with something like that, you have to be careful because you might be dealing with an inflammatory breast cancer. This is just another example. Echogenic fat, skin thickening, focal dilated duct, echogenic fat. This is picture of mastitis. Another example, anechoic fluid, internal debris, posterior acoustic enhancement, echogenic fat. This is typical of abscess. This is bi-rads 2 with the classic scenario and clinical symptoms. You put a needle, you aspirate, and the patient will improve with antibiotic treatment. This is bi-rads 2 or bi-rad 3. If you are not sure, you can follow it up. So we finished now the ultrasound features. So this is just a quick idea about the ultrasound. You need to memorize what are the features of malignancy, what are the features of benign lesions. You characterize the lesion first. I ask myself a question. Am I dealing with bi-rads 2? What is bi-rad 2? Bi-rad 2 is anechoic cyst. If it doesn't fit with cyst, am I dealing with bi-rad 3? What are the features of bi-rad 3? Oval shape, well-defined, homogeneously hypoechoic, thin capsule. If any of the feature doesn't fit with bi-rad 3, immediately you go to bi-rads 4. So it means you're dealing with indistinct margin, angular margin, microlobulated margin, spiculated margin. You don't have the thin echogenic capsule, you have thick echogenic capsule, then most likely you're dealing with malignant lesion. bi-rads 4, you need to biopsy. Moving into breast MRI. So this is a really big topic, would be difficult to cover, but I will try to give you just a quick idea that you keep in mind. So these are the indication of breast MR. I would advise you guys in cases of the exam, you're preparing for exam, you memorize 3 or 4 of the And then you have to know your MR lexicon. What is the MR lexicon? So whenever I'm looking at MRI, there are three things that you have to keep in mind. Am I dealing with mass? Am I dealing with non-mass like enhancement? Or I'm dealing with a focus? Similar to what we talked about in mammogram. Mass is a 3D space-occupying lesion. Whenever you're dealing with a mass, there are three things that you have to describe. You describe the shape of the lesion, the margin, and the internal enhancement of the lesion. If you have smooth margin, most likely it is benign. If you have irregular spiculated margin, most likely you're dealing with malignant lesion. Shape of the lesion, round, lobular, oval, this is usually benign. Irregular shape, usually malignant. Internal enhancement is very helpful. Homogeneously enhancing, it means benign. Heterogeneous enhancement, it means malignant. Dark internal septation, it is usually described in fibroadenoma. However, it's not very specific. Enhancing septation is usually suspicious. Central enhancement is usually suspicious. So if we look at the shape of the lesion, so rounded lesion, oval lesion, oval, rounded, I'm dealing with a benign lesion. Microlobulated lesion, depending on the size, looks a little bit irregular in shape. This by means it is suspicious bi-rads 4. Irregular lesion with spiculated margin, this is very suspicious bi-rads 4 or 5. Internal enhancement, very homogeneously enhancing, I'm dealing with benign lesion. Very heterogeneous enhancement, areas that appears hyper-enhancing, areas appears washing out, very suspicious. Heterogeneous enhancement, again, with irregular lobulated margin, very suspicious bi-rads 4. This lesion, you can see that there is non-enhancing internal septation. This is in keeping with benign, usually seen in fibroadenoma. However, it is not specific. It has been described in malignant lesions. So when I see it, I don't depend on it. I just describe it, but it cannot differentiate benign from malignant. So we finish masses. Now we move into non-mass. Non-mass, guys, it's very similar to microcalcification. So you remember when we talked about microcalcification, we talked about two things. We talk about the morphology of the micro and the distribution. In cases of non-mass-like enhancement, I talk about distribution. So these are the typical descriptive terms: focal, linear, segmental, regional, diffuse, or multiple region. If you have focal enhancement, it could be benign, could be malignant. It depends on the internal enhancement. If you have linear non-mass-like enhancement, it is by bi-rad lexicon, bi-rads 4, needs biopsy. If you have a segmental non-mass-like enhancement, it's a bi-rads 4. If you have regional, it could be benign or malignant. If you have diffuse, it's usually benign. If you have multiple regional, it could be benign, could be malignant. Internal enhancement, again, it could be helpful. Homogeneous enhancement is usually benign. Heterogeneous enhancement, suspicious. Stippled, suspicious. Clumped, suspicious. And this is just an example. So if you have a breast, you have segmental area of non-mass-like enhancement. This is bi-rads 4. It has to be biopsied. Just another example, if you have an area of linear non-mass-like enhancement, it is suspicious. If you have a regional, then I need to do further investigation. Is it homogeneous, heterogeneous? What's the kinetic curve enhancement of that area? And then it depends on the most suspicious feature. It's either bi-rad 3 or bi-rads 4. asymmetric, it could be benign, could be malignant. I have to assess further the other images. Multiple region, if it's very asymmetric, it is suspicious. If it's symmetrical, it is most likely benign. Diffuse, if it's asymmetric, very suspicious. If it's symmetrical, it's very benign. So when you look here, for example, you see that right and the left breast, you see that there is diffuse asymmetric enhancement in this breast. The other breast is not enhancing. This is very suspicious for diffuse infiltrative breast cancer. You look here, there is diffuse bilateral symmetrical enhancement. This is benign, nothing to worry. Stippled, when you see an areas of multiple area of punctate enhancement similar to this, looks like bunch of grapes appearance. This is suspicious for ductal carcinoma in situ. You have to biopsy this area. So we said when we talk about enhancement, the non-mass-like enhancement, we did the morphological assessment. What is the distribution? And then you have to do what we call kinetic curve analysis. What's the kinetic curve analysis? Kinetic curve analysis is you want to see the area of enhancement, how does it enhance over the coming 6 minutes. So you have 3 types of curves in kinetic enhancement. If you have an area that took the enhancement rapidly at the beginning over the first 90 seconds, and then it kept progressively enhancing. This is what we call progressive enhancement. If you put your ROI or you do your kinetic assessment for that lesion, and you see that kind of curve, then most likely you're dealing with a benign lesion. The second curve is what we call a plateau type of enhancement, where you see that that lesion will take enhancement within 90 seconds, and then over the next 6 minutes, it will plateau. It will not change. This is sort of, it could be benign, could be malignant. However, they found that 60% of the time of this type, it's usually malignant. If you see that the lesion is taking up immediately the enhancement, and then over the 6 minutes, it's washing out, this is suspicious. This is usually found in malignant lesions. So progressive, plateau, washing out. Benign, could be benign or malignant. This is malignant. So this is your kinetic assessment of the enhancement. So as we said before, you will assess the morphological enhancement of the lesion. Is it mass? Is it non-mass? How does it enhance? Does it follow specific distribution? And then you will do your kinetic curve analysis. So this is how we do it. This is the area of enhancement. You put your ROI, and then the workstation will give you, or the software will give you, the kinetic curve assessment. This is sort of washing in and then plateauing. This is washing in and then progressively enhancing. This is benign. So what's your MR algorithmic approach? How do I approach the lesion on MRI? So the first thing I always do, I always say my first step is I look at the MIP image. The MIP image will give you a quick idea about how does the breast is enhancing. Once I see an area that is enhancing, I will go to assess that area on the 2T sequences. Is it bright signal intensity, or is it intermediate or iso intense? If it's bright, it's usually benign. If it's iso intense, I would be careful and suspicious about it. And then you will go to T1 sequences. Look for any areas that appears bright on T1 fat saturated sequence, because it means that there is hemorrhagic or proteinaceous material. If you see a lesion that is enhancing, you will go and assess what's very important, shape, margin of the mass. And this is the most important features on MRI. Your morphology assessment, shape and margin is very important. It is even more important than the kinetic assessment. If I see the lesion is spiculated, irregular in shape, irregular margin, it is directly bi-rads 4 regardless of the kinetic assessment. If the lesion is well-defined, benign looking, And then you always keep in mind, guys, we assess morphology and kinetic. Whenever one of these is suspicious, it will upgrade the lesion. Meaning, if you have a well-defined lesion, but it has a washout kinetic, this means that this lesion is a bi-rads 4. If you have speculated lesion with a progressive enhancement, this is a bi-rads 4 or 5 lesion. So you always go by the most suspicious features, either on morphology or on kinetic curve analysis. Okay, so now we finished. Just I gave you a quick idea about the breast MRI. We will move into interventional breast procedures. I think this part, guys, you just need to know what are the types of the procedures, and for people who are preparing for the exam, you have to know which one to use depending on the type of the lesion. So you might hear about stereotactic guided breast biopsy. What is a stereotactic guided breast biopsy? Stereotactic, this is how it looks like. This is a table. Patient will lie prone on her tummy. The breast will be hanging from this part, and then we will do the biopsy using X-ray. What we do is we do 15 plus, 15 minus. We will have 2 images similar to this. So if you have a mass, I will have the 15 plus and the 15 minus image. I will have the mass on both views. I will put my X on the mass. The computer will calculate for me the X, Y, and Z location of the lesion, and I will be able to do the biopsy using the X-ray. So this is how it looks. In cases of microcalcification, the same thing. I will do 15 plus, 15 minus. I will put my X. Computer will calculate the location, and I will be able to do the biopsy. This is pre-firing. The needle is inside the breast already. Before I fire it, and you can see the microcalcification, and then I will do the biopsy. Once you do the biopsy, this can come in the exam. So what is the name of this image? This is X-ray of a biopsy specimen. What's the use of this X-ray? The use is it can tell that when I did the biopsy, I got the microcalcification. So this means that this is a successful biopsy. Once you are done with a stereotactic guided biopsy, you will put a marker, and then you will do a mammogram post-biopsy to know that you have biopsied the microcalcification, and you know that the marker, it is in a good location at the site of the biopsy. What is stereotactic needle localization? Stereotactic needle localization is a localization using X-ray or mammogram. So for example, I have this group of microcalcification in the left breast. I want to help the surgeon to know how to resect this. So this, you have to know what's the name of this image. This is what we call alphanumeric plate. It has A, B, C, D, E, F, G, H, I, and then you have the numbers. So this is used to localize the microcalcification. So it is used for localization. I will do this image. I localize the microcalcification here. It is located here. So I'm gonna go and put my needle at the intersection of 7 and G, as you can see here. And then I will continue. And then I can see that now this is the micro, this is the needle. I have to insert the needle a little bit further until I reach, and then I will do the hooking of the needle, and I will send the patient for surgery. Once she is gone for surgery, we do X-ray of the surgical specimen, and you can identify either a clip or the microcalcification within the surgical specimen. Ultrasound guided biopsy and needle localization is another way how to do the biopsy. So generally speaking, let's say, when do I use stereotactic guided biopsy? So stereotactic guided biopsy, it is usually used to biopsy microcalcification that are not associated with masses, or it can be used for an area of architectural distortion that you don't see on ultrasound, or it can be used for biopsy of a mass that is seen on mammo, but I cannot identify So anything you cannot see a correlate with the ultrasound for it, you use the stereotactic guided biopsy. Usually it is used for microcalcification. What is ultrasound guided biopsy used for? So it is usually used for aspiration. You use it for biopsy of a lesion that is bi-rads 4 or 5. You use it for vacuum-assisted biopsy. You can do clip placement of a lesion, or you can do needle localization before the surgery. What's the advantage? So ultrasound is the best way to do the biopsy. Why? Because it's very easy, it's comfortable for the patient, and it's very quick, and there is no radiation exposure. How do you prepare the patient? So usually patient is put on an oblique view. You put the side of the breast that you want to biopsy up, and then you can use any of these needles to biopsy the lesion with ultrasound. You have your probe, and then you will go either lateral or medial approach. Your needle always will be parallel to the chest wall. You will never go perpendicular, and you will insert your needle and do the biopsy. So for example, this is an example. You see a well-defined or speculated lesion on mammogram. I do the ultrasound. I see that it is slightly lobulated, has slightly angular margin. It doesn't have thin capsule. So this is a bi-rads 4 lesion. So I will go and I will do the biopsy. You see how the needle is located parallel to the chest wall. This is your chest wall. I don't go perpendicular. It is parallel to the chest wall. I take an image pre-fire. I take an image post-fire. I do 4 or 5 core biopsy from the lesion. Once I'm done, I will put a clip within the lesion to document that I've been biopsied this lesion. The other way is, or the other procedure that you can use under ultrasound guidance is cyst aspiration. You put a needle, you aspirate the cyst, and that's it. What is a vacuum-assisted biopsy? So for the R4 preparing for exam, you have to know what is the indication of vacuum-assisted. So the commonest indication for vacuum-assisted biopsy is if you have a complex cystic lesion. So if you have a complex cystic lesion, I don't do core biopsy. I do vacuum-assisted biopsy. The idea of it is you want to take as much as you can and you remove that complex cystic lesion. You can use it as well in cases that you've done a core biopsy of that lesion and then the biopsy result is discordant with the finding that you've seen. There's no significant contraindication. I would try not to use the vacuum assisted if the patient is on warfarin or heparin because the size of the vacuum assisted biopsy is usually large. So when we do a core biopsy, the size of the, and this is important to keep in mind, guys, the core biopsy, we usually use a 14 gauge needle. Vacuum assisted biopsy, we usually use a bigger size needle. What is the size available? It's ranging between 7 and 12. So some, depending on the type of the machine you're using, some they have 7, some they have 8, 9, 10, 11, and 12, usually big size. What are the patient preparation? Very similar to any other biopsy. You would ask the patient to have usually a coagulation profile. We'll be sure that she's not on anticoagulation. She's not using aspirin. She should be informed about the procedure very well, and then you will do the biopsy. This is just an example in core needle for a vacuum-assisted biopsy in case that comes in the OSCE. This is example of a complex cystic lesion. So you see that this is a focal dilated duct. You can see that there is an internal solid component. This is a complex cystic lesion with an echogenic component. I would go behind the lesion. I would do complete suction of this lesion, and then I would put a clip at the site of the biopsy. Ultrasound guided needle localization is very similar to the mammogram needle, but we do it under ultrasound guidance. So for example, you have a lesion here. I will go with the needle, localization needle, insert it, and then send the patient for surgery. You see here is the needle. You hook the wire, and then you send the patient for the surgery, and then they will do an X-ray of the specimen to be sure that the lesion was resected. MR guided biopsy, what is it used for? It is used usually for a lesion that is visualized only with MRI. The preparation is very similar, guys, to the vacuum-assisted biopsy because we use the same thing. The needle that we use in MRI guided is the same needle that I showed you here to be utilized in ultrasound vacuum-assisted. So I use the same needle. However, the needle used is usually MR compatible, but it's the same device. So when do we use MR-guided biopsy? We use it in cases of lesion or non-mass-like enhancement being only visualized on MRI. This is how it looks like. The breast coil, patient will be lying here, her head will be here, breast will be hanging here, and then this is the pieces that we use in cases of MR-guided localization. We will put this piece, we will identify the location of the lesion, and then we will do the biopsy. So I will not explain to you the details of the procedure, but this is how we do it. So if I want to go through the summary, guys, so now, over the last 45 minutes, we learned the following. You learned what are the features of solid and cystic lesion on ultrasound. You learned how to differentiate between benign solid and malignant solid lesion. You learned what's the difference between complicated cyst and a complex cystic lesion. You learned the bi-rads of these features. You learned what are the features of bi-rad 3 lesions. You learned what are the features of bi-rads 2 lesion, and you learned what are the features of bi-rads 4 lesion. We talked about MRI bi-rad lexicon, so you know that you have a mass, you have a non-mass-like enhancement, you have a focus. When you have a mass, you describe the shape, the margins, the internal enhancement, the kinetic curve assessment. When you have a non-mass-like lesion area, you describe the distribution of the non-mass-like enhancement. You describe the internal enhancement characteristic of the non-mass-like enhancement. You describe the kinetic curve assessment of the lesion. We learned that whenever you have a suspicious feature, regardless, mass or non-mass-like enhancement, you always go by the most suspicious. So if the morphology is suspicious and the kinetic is benign, the final bi-rads category is suspicious. If the morphology is benign and the kinetic is suspicious, then the final bi-rads category is suspicious and you need to do biopsy. We learned about the interventional procedure, guys. So you had to understand what is stereotactic guided biopsy. You learned about the 15 plus, 15 minus appearance. You learned that whenever you do stereotactic guided biopsy, you will take X-ray of the specimen to be sure that there is microcalcification in the X-ray of the biopsy specimen. You learned that we always put a marker. You learned that once we finish the biopsy, we do mammogram to be sure that the marker is located in a good location of the biopsy. You learned about the core biopsy. What is the size of the core biopsy? It is 14 gauge. You learned when to use ultrasound for biopsy. You learned about what is the indication of vacuum-assisted biopsy. What is the size of vacuum-assisted biopsy needle? It's usually ranging from 9 to 12 or 13. We always put a marker post-biopsy, and then you learned as well, when do we use MRI-guided biopsy? Whenever we have a lesion that is visualized only on MR and not seen on anything else. So this is just a summary for everything, guys. I hope that was helpful for you, and I'm happy to listen and answer any question.
Thank you very much.
No problem.
So we'll start with the first question from Dr. Hiba.
Okay.
She's asking what's the difference between distortion and asymmetry?
Okay, so asymmetry, we said it is a spectrum. Asymmetry, if it's a global asymmetry, then you have a large area that looks different between right and left. Global and focal asymmetry, you see it on 2 views. Asymmetry, you see it only on 1 view. Developing asymmetry is when you see something on new on Distortion is where you see only spicules without underlying mass. So distortion is usually suspicious. Okay?
Okay. So the next question, is it necessary for all calcifications to have milk of calcium to consider it as bi-rad 2?
Okay, so that's a good question because as we said, whenever you have a suspicious, a microcalcification like grouped or segmental or something like that, we said we do magnification view and a true lateral. If you have areas of milk of calcium in between this microcalcification, then most likely you are dealing with a benign, because presence of milk of calcium in between these microcalcification, it's usually benign. However, if the microcalcification is pleomorphic or looks amorphous and you see a small area of milk of calcium very far from the rest of the microcalcification, then you shouldn't consider it as a bi-rads 2. But generally speaking, if you have 2 or 3 areas of microcalcification with milk of calcium, most likely you're dealing with benign feature.
Okay, Dr. Talal asking, could you repeat the indications of stereotactic guided biopsy, please?
Okay, so the stereotactic guided biopsy, it is usually used for microcalcification most of the time. As I told you before, any microcalcification, your next step, you do magnification view and true lateral magnification view. Once you identify that this is suspicious micro, your next step is you do ultrasound. Why? Because with ultrasound, I want to identify if there is an associated mass with this micro. If there is no mass associated on ultrasound, I would go back and I would do biopsy for the microcalcification using stereotactic guided biopsy. So it is mainly used for microcalcification. Other indications is if you have architectural distortion and you cannot identify it by ultrasound, or you have an area of asymmetry or developing asymmetry, and also you cannot identify it with ultrasound.
Okay. The next question, what is the next step for pathologically proven fibroadenoma? Do you still follow it up at least yearly?
So usually, if it's a fibroadenoma post-biopsy, I would follow it up for 2 years. Like I would do 1 year and 1 year until I complete 2 years, and that's it. I would downgrade it to bi-rads 2. If I biopsy it and I was not sure this is a fibroadenoma, I would do 6 months, 6 months, 1 year. So generally speaking, to make it easy for you, even after biopsy, follow up the fibroadenoma for 2 years.
Okay. Dr. Abdulaziz Al-Massan asking, is there bi-rad 0 on ultrasound or MRI?
Okay, that's a good question. So bi-rad 0 on ultrasound, usually no, you should be able to characterize it. Sometimes we use bi-rad 0 on ultrasound when you don't find a finding on mammo or ultrasound corresponding to each other. For example, you see an asymmetry or developing asymmetry on mammogram, and you do the ultrasound and you still cannot find anything correlating. What's your next step? Your next step, if you're suspicious, you would go ahead and biopsy that area with mammogram. But you have another option. You can call it as a bi-rad 0. You go ahead and you do an MRI because that area could represent an area of asymmetric fibroglandular tissue. So generally speaking, I would be very conservative using bi-rad 0 after ultrasound and MRI. You should be able to give a final bi-rads after ultrasound and MRI.
Okay. The next from Dr. Adua. There is a new bi-rad systems. For the practice and exam, shall we follow the 2013?
Yes, I would follow 2013.
Okay. Also, Dr. Abdulaziz asking, is there any additional value of color mapping on MRI?
Not really. Color mapping is very similar to kinetic. So if you do the kinetic curve analysis, this would be very helpful because color mapping is very variable depending on the software that you're using.
about the elastography. Does it add much to ultrasound diagnostic capability?
So elastography is helpful in differentiating, generally speaking, and this is where elastography came out, in differentiating between bi-rad 3 and 4A. So it is helpful, but I would say that the specificity is very low. So I wouldn't use it except like at a resident level. I would be very careful in using it differentiating 3 and 4A.
Okay. Dr. Sarah asking, what do we need to know about breast elastography?
You need to know the type of breast elastography. So there is the shear wave elastography and the strain elastography, the two types. You need to know what is the added value of elastography. So elastography, usually it differentiates between soft and hard lesions. So soft lesion like fibroadenoma, like cyst, hard lesion like malignant lesion. But keep in mind that there is significant overlap between this. And that's why I would say always it's very difficult to be utilized at resident level in differentiating bi-rad 3 and bi-rad 4A lesion.
Okay. Dr. Muhammad asking, can I use bi-rad system depending on one modality?
No, because when you use mammo and ultrasound or ultrasound and MRI, you have at the end to give a conclusive assessment bi-rad. So for example, if the patient is coming for screening only mammo, then you will give bi-rads for the mammo. But when she comes for mammo and you do ultrasound, at the end, you cannot leave the mammo bi-rad 2 and the ultrasound bi-rad 4. The final assessment should be the highest. So I always give at the end 1 bi-rads for each breast. So that's why when we do mammo ultrasound, I would give 1 report for both of them. And I would say that the right breast bi-rads is, for example, 3. The left breast bi-rads is bi-rads 2. And you always go with the most suspicious features.
Okay. The next from Dr. Sarah. Could we differentiate between mastitis with abscess versus galactocele?
Yes, galactocele, usually patient is lactating. Usually you see a well-defined wall and you might see no surrounding inflammatory reaction. So the fat will not be inflamed. There is no skin thickening. You might see fluid level. In cases of mastitis or abscess, you will see very irregular shape collection. You will find that the fat is echogenic. You will find overlying skin thickening. In some cases, there is overlap between the galactocele and abscess. I do agree that sometimes it's very difficult to differentiate.
Okay. The next from Dr. Abdul Khaliq. Is thick/thin echogenic capsule on ultrasound considered as a bi-rad lexicon term?
As I said before, no, because it used to be on the previous edition, not the last one, but I still find it one of the most helpful features. It was described by Dr. Sickles. He's the godfather of breast ultrasound, and I find it's one of the most helpful. So whenever you find the thin echogenic capsule, this is really benign. Whenever you have thick echogenic capsule, it is very suspicious.
Okay. One long question from Dr. Sarah. Kinetic curvature, the latest studies started to depend on the initial enhancement. If it rapidly enhances within the 2 minutes, it is most likely malignant lesion without giving that much concern, without giving that much concern to washout. Should we depend on that on the exam setting or on the classical way that we have been taught?
I think it's a good thing to know about the update that rapid wash-in is suspicious for malignancy, but for exam purpose, I would always talk about the type of the curve. So progressive, wash out, or plateau, because this is what comes in the last edition of bi-rads, it does not state that wash-in is the only feature. Wash-in is very helpful in cases of screening breast MR, because breast MRI, in cases of screening, we do what we call abbreviated breast protocol, meaning that we do only the first 2 or 3 phases of breast MR. And based on that, you will look only for the enhancement on the early phase. But in cases of diagnostic, we have to do the 6 or 7 minutes or 8 minutes protocol, which will give you an idea about the wash-in and what happens later on. So what I would advise, for exam purpose, you should know the kinetic curve analysis of the lesion.
Okay, what are the indications of ultrasound-guided aspiration?
So for cyst that is usually painful, I would aspirate. Otherwise, I wouldn't do it for anything else, and in cases of breast abscess.
Okay, Dr. Sarah asking, what are the features of complex cyst on ultrasound?
So there is nothing called complex cyst. We said it's complex cystic lesion. So complex cystic lesion that has thick internal septation, solid internal component, internal vascularity, or a solid lesion with lots of cystic changes. So this is the description of a complex cystic lesion.
Okay. Dr. Yasser is asking, can we bi-rad each breast differently?
That's what I usually advise. So because sometimes the bi-rads is benign on one side and malignant on the other side. So I give bi-rads for right and bi-rads for left.
Okay. So many questions. Dr. Abdelmalik is asking, any difference between malignant features on ultrasound between males and females?
It is the same for both.
Okay. Dr. Arim asking, can you please repeat the specimen radiograph part?
So,
and what do we need to know for the exam?
So specimen radiograph is an X-ray of the surgical specimen. So patient went for surgery, they resected part of the breast, for example, an area of microcalcification, and then you do X-ray for that surgical specimen. And you want to see, is the clip is there? Is the microcalcification is there? Is there is good margin around the area of the suspicious lesion?
Okay. Dr. Omar is asking, what is the best modality to start with in young versus old, males and females, and why?
So generally speaking, female below 40, I start with ultrasound. If I see it's suspicious, I proceed with mammo. In male, generally, I like to do ultrasound. Again, most of the time it's gynecomastia, so I don't need to expose the patient to radiation. If I'm not sure, then I would proceed with mammogram.
Okay. In screening mammography, is it necessary to do ultrasound in dense breast?
It is usually very important because there is very high chance that you might miss cancer. So screening ultrasound in dense breast, it can pick 3 cancer in 1,000 patients. So you might miss 3 cancer in 1,000 patients. So always I would say, if the patient is coming first time with dense breast, I would do ultrasound.
Okay, Dr. Hassan is asking why architectural distortion is not considered a type of asymmetry.
It's a very, I don't have an answer because bi-rads, as I said before, bi-rads lexicon, they divided it as a special feature. So asymmetry is something has no space occupying feature. Architectural distortion is very similar to mass, so it's not part of the asymmetry.
Okay, Dr. Riyad is asking, what is the indication of harmonic ultrasound?
I would advise to use harmonic with every single exam because it does help you differentiating solid from a cystic lesion. But there's no clear indication. It's just part of your assessment as general ultrasound.
Okay, finally we reached to the last question. Could you please repeat minus 15 plus 15 method?
So
technique?
15 and plus and minus, I want you just to know how does it look like, because it might come in the OSCE and they ask you what's the name of these views. So usually, very difficult to explain it now because it's not like I don't have a video, but generally speaking, you will put the patient on stereotactic table and then you will move the tube one time to the right and one time to the left. of the X-ray projection is sometimes 15 plus on the right side and 15 plus and 15 minus on the other side. So the intersection between the two X-ray projection, it will give you the X, Y, and Z measurements for the location of the micro. So difficult to explain to you, but if you have a stereotactic table, you should go and ask your technician and show you how to do it. You need, for exam purpose, you need to know how it looks like, and you need to know what is it used for, and that's it.
Thank you very much, Dr. Nawaf, for this interesting and well elaborated point. Thank you again for the accepting our invitation, and we wish to meet you soon, inshallah ta'ala.
Inshallah. Thank you so much for the invitation. Wish you the best of luck for everyone, guys, and I hope to see you soon.
Jazakallah khair. Thank you all.
Thanks, doctor. Thanks. Have a good day.
You too.